You said two things. The first one I wanted to kind of spend some time on, right? So with targeted therapies, for the most part, they tend to be a little bit generally tolerated, better tolerated than our traditional chemotherapies. Here we're kind of merging two types of therapies, and we're having to get comfortable with different types of toxicities like we did with immunotherapy. And so I wanted to spend a moment in thinking about, in talking specifically stating some of the unique toxicities that we see with these bispecifics and these antibody drug conjugates. And also, as part of that conversation, focus a little bit on that hypersensitivity reaction. When do we expect it? Is it something that should make doctors practicing in the community, patients pause and kind of not push forward with the therapy?
So I'll take the last part of your question first, the infusion reactions. Remember, those are proteins, right? So both antibody drug conjugates as well as bispecifics are proteins. So the patients will react to the foreign proteins. The reactions are generally fairly mild. Like, for example, amivantamab, we have to separate the day one in two doses, give a little bit of the chemo treatment first, and then you give complete the full dose on second. It's very similar in management, like what we see with Rituxan, sometimes with cetuximab. So the infusion reactions are generally not bothering me. The other toxicities that you mentioned, I certainly can be difficult to manage. Like, for example, the CCAM antibody drug conjugates have mucositis. Some sacituzumab has mucositis as well. And mucositis are very uncomfortable for our patients. It's painful. You have to minimize what you eat and what kind of quality of food you take. And there is not a good treatment options for us to manage the mucositis. And then another example is pneumonitis, for example, with the trastuzumab deruxtecan, the HER2 antibody drug conjugate. The rate of pneumonitis is pretty high. It's about 14-15% in the most recent studies. And we know how to manage pneumonitis in general. But, the patient developed pneumonitis, especially if they develop more severe pneumonitis, that means that the drug is not going to be able to be given to them afterwards. And at this point, we really don't have any idea which of those patients will develop pneumonitis upfront. We haven't been able to identify the specific characteristic of the patient that will tell me, okay, this patient is going to develop pneumonitis and this patient will not.
I think we need Dr. Iyengar's tools, right? I think we need to be just as precise in our kind of prediction of efficacy as we are with toxicity, right? I think a lot of our focus has really been on efficacy.